Okay, let's unpack this. We're about to dive deep into a condition that's rare but incredibly serious. It's called Neuroleptic Malignant Syndrome, or NMS. We've been working with a really insightful source here, an article titled Neuroleptic Malignant Syndrome, Recognizing and Addressing a Rare Danger. And it's given us a clear mission to really understand this potentially life-threatening reaction, that can happen with certain medications.
And that word rare, I think, can sometimes make us feel like, oh, okay, we don't need to worry too much. But as the source makes really clear, when NMS does occur, it's an absolute medical emergency. Every moment counts. So understanding it is vital, especially for anyone who might encounter it, whether patient, family, or clinician.
Absolutely. So maybe let's start right at the beginning. What exactly is neuroleptic malignant syndrome?
Okay, so think of NMS as a severe and importantly kind of unpredictable reaction. It happens with certain medications, mainly antipsychotics. It's described as idiosyncratic, which just means it pops up in specific individuals without a clear pattern we can always, foresee. Biologically, it seems tied to how these drugs interfere with dopamine pathways in the brain. And that interference then throws the body's autonomic nervous system, well, pretty much into chaos.
Right. And these antipsychotic medications, they're used for really significant conditions, aren't they? Like schizophrenia, bipolar disorder, other psychotic disorders.
That's right. Yeah, they're crucial tools for managing some very serious mental illnesses. Our source actually points to updated data from the American Psychiatric Association in 2024. It indicates NMS occurs in about 0.01% to maybe 0.02% of patients treated with these drugs.
Okay, so really small numbers.
Tiny percentages. But if you look at it over time, it's estimated at roughly 1 to 2 cases per 10,000 patient years.
Yeah.
So rare, yes, definitely. But given how many people take these medications globally, it's still something healthcare providers and patients, frankly, need to have on their radar.
It's kind of amazing that it was first identified way back in the 1950s with chlorpromazine, and even with all the medication advancements since then, it's still a risk. And the source says it can come on quite quickly, like within hours or maybe weeks of starting, or even just increasing a dose.
Yes, exactly. And that speed is definitely part of the danger. The mechanism, it seemed to tie back to that dopamine blocking action. Antipsychotics essentially put a block on dopamine receptors. In some people, perhaps those who are more vulnerable, this widespread blocking effect, especially where dopamine controls muscle movement and temperature, well, that leads to the severe muscle rigidity, the high fever, and all the metabolic chaos we see in NMS. What's truly striking, though, and something the source really emphasizes, is the mortality rate. Despite how rare it is, if NMS isn't recognized and treated fast, the mortality can be somewhere between 5% and 11%.
Wow.
Yeah, a Journal of Clinical Psychiatry review cited in the article highlights this. That contrast, how infrequently it happens versus how incredibly dangerous it is when it happens. That's really a key takeaway here.
That really underlines why recognizing the symptoms is just so critical. But as the source details, that's also where one of the biggest challenges lies, isn't it?
Absolutely, a huge challenge.
Hmm.
Because the symptoms of NMS, well, they aren't unique. They don't scream NMS immediately. They can look like a whole lot of other serious medical emergencies.
Like what?
Things like malignant hyperthermia, which is often related to anesthesia or severe infections, sepsis, even something called serotonin syndrome, which
Yeah.
we can maybe touch on again later. It makes misdiagnosis a really significant risk.
Right. Our source lays out what they call the classic tetrad, like a group of four key symptoms that often show up together. You've got a very high fever, often shooting over 38 degrees C or 100.4 degrees Fahrenheit. Then there's severe, really intense muscle rigidity, like all over. You also see altered mental status, so anything from confusion and agitation right up to slipping into a coma. And finally, that autonomic dysfunction, which means the body's automatic systems like breathing, heart rate, blood pressure, they just go haywire.
Exactly. Unstable blood pressure, maybe lots of sweating, or a super fast heart rate, tachycardia. And these things can escalate frighteningly fast, sometimes within just, say, 24 to 72 hours. The problem is, like you said, these symptoms taken along. A high fever could be flu, could be infection, muscle stiffness, maybe pulled muscle or some other neurological thing, altered mental status, so many potential causes.
And there's a really crucial point the source makes here. NMS isn't just like a really bad side effect you push through. It's a distinct, life-threatening medical emergency. It needs specific, immediate intervention.
And this raises, I think, a really important question, especially for healthcare providers in busy settings like ERs. How do you make sure you don't just see these symptoms as, a cluster of bad reactions, but specifically think, Could this be NMS, and test for it.
Because the consequences of delay sound awful.
They are. The source is pretty blunt about it. Rhabdomyolysis, that's the breakdown of muscle tissue, can happen fast. That releases proteins that can overwhelm and damage the kidneys, potentially leading to acute kidney failure. Respiratory distress is also common. The article even notes that mortality risks actually seem to increase hourly with delayed diagnosis and treatment.
Hourly?
Wow. Yeah. And that lack of awareness, not just maybe in the general public, but sometimes even among medical staff who just don't see many NMS cases, that clearly makes the problem worse. Education seems paramount.
Okay, so education is key. Now, who is more likely to experience this? I mean, it's rare, but are there factors that increase the risk? What does our source pinpoint?
Well, the biggest trigger highlighted in the source is actually how the medication is started or changed. Using very high doses right off the bat, or increasing the dose too quickly, what doctors call rapid titration, that significantly bumps up the risk.
Okay, so the dosing strategy matters a lot.
A lot. Beyond that, certain patient factors seem to play a role. Individuals with a history of mental health conditions, where maybe agitation or catatonia is a feature, they seem to be more vulnerable. Also, things like dehydration, exhaustion, or even being physically restrained during treatment are listed as potential contributing factors.
That's really interesting that those sort of external physical stresses can play a part. I also noticed the source mention a 2023 study in the Psychopharmacology Bulletin. It pointed to men under 40 maybe being more susceptible.
Yes, that finding was mentioned. And also, very notably, individuals who have actually had NMS before are at higher risk of getting it again if re-exposed.
Which suggests maybe some underlying vulnerability.
Exactly.
Yeah.
It suggests there might be some underlying genetic factors or physiological predispositions that make certain people uniquely sensitive to this dopamine blocking effect.
Then what about the medications themselves? Are certain antipsychotics more likely culprits than others?
Historically, yeah. The older ones, the so-called typical antipsychotics like haloperidol, chlorpromazine, they were more commonly implicated. This is probably because they're very potent blockers of a specific dopamine receptor, the D2 receptor.
Okay.
However, the newer ones, the atypical antipsychotics, things like clozapine or risperidone, they can absolutely cause NMS too.
Yeah.
Especially maybe if a patient is on multiple medications, what we call polypharmacy, or if the drugs are used off-label outside their standard indications.
And it's not just antipsychotics.
Right. What's perhaps a bit surprising is that other medications that also have dopamine blocking properties can contribute. Even some common anti-nausea drugs like metoclopramide have been implicated in NMS risk.
Wow. Okay, so the picture broadens a bit beyond just psychiatric meds. And you mentioned external factors earlier, like environment.
Yes, the source touches on that too. Environmental things like really hot weather or maybe intense physical overexertion might potentially exacerbate the risk. The thinking is this could stress the body's temperature regulation system, making it harder to control that high fever we see in NMS.
Okay, so putting all this together, you've got these symptoms, these risk factors, but it's hard to distinguish from other conditions. How do doctors actually diagnose NMS? Since, there's no single blood test that just says, yes, it's NMS.
That's fundamentally a clinical diagnosis.
Sure.
That means doctors have to rely really heavily on the patient's detailed history. What medications are they taking? When did the symptoms start? How did they progress? All that history. And they combine that with the specific presentation, looking for that tetrad of symptoms we talked about. And then, crucially, they have to rule out all those other conditions that could be causing similar issues.
So it's a process of deduction almost, looking at the whole picture and eliminating other possibilities.
Pretty much, yes. It's careful clinical reasoning. Now, supporting lab findings are also important, even if they aren't definitive on their own. Elevated creatine kinase levels, CK levels, that's a classic finding. It shows muscle damage from that severe rigidity.
Ah, okay.
And abnormal liver function tests can also sometimes be present. There are also some diagnostic tools available, like the Levinson criteria. It's essentially a scoring system. Doctors use it to assess the likelihood of NMS based on the presence and severity of different symptoms and lab findings. A score of 9 or higher suggests NMS is probable.
Okay, so the Levinson criteria is like a checklist or a scoring system to help formalize that assessment. Makes sense. You mentioned the overlap with serotonin syndrome earlier. How do they typically tell those two apart? Because that sounds like a key challenge.
It really is a key diagnostic challenge. Serotonin syndrome shares some features, like fever and altered mental status, absolutely. But the cause is different. It's caused by drugs that boost serotonin, not block dopamine. And also the muscle issues tend to be different. In serotonin syndrome, you often see more like twitching, tremors, hyperreflexia, kind of jumpy reflexes, whereas NMS is characterized by that profound, almost lead pipe-like rigidity, very stiff.
Got it. Rigidity versus twitching.
Exactly. So distinguishing between them requires really careful attention to the specific symptoms and a thorough review of the patient's full medication list. This is why a comprehensive evaluation is so essential, often involving blood tests, maybe brain imaging, and consultations with specialists like neurologists or psychiatrists. Because, as the source stresses over and over, misdiagnosis means delaying the correct, potentially life-saving treatment for NMS.
Okay, now here's where it gets really interesting, I think. The source includes a real-life story, and it just brings all these clinical points home in such a powerful way. Can you share that case? The one about the 28-year-old woman?
Yeah, this case is, well, it's a stark reminder of everything we've been discussing.
Yeah.
It involved a 28-year-old woman who was being treated for schizophrenia.
Yeah.
She was started on haloperidol, one of those typical antipsychotics, for an acute episode of psychosis. Within just 2 days, I mean, think about that speed. 2 days, she developed severe muscle stiffness and a really high fever. It hit 39.5 Celsius, which is 103 Fahrenheit.
Wow.
And her family, crucially, they were clearly vigilant. They noticed she was confused and breathing rapidly. They got her to the emergency room.
Okay, good. But initially, even with those pretty clear symptoms, she wasn't diagnosed with NMS.
No, tragically, she wasn't. The initial diagnosis, according to the source, was actually a suspected viral infection.
Oh, no.
Yeah. But her condition didn't improve, of course. It worsened. It was only when repeat lab tests came back showing severe rhabdomyolysis, that muscle breakdown marker we talked about, and elevated liver enzymes, that the picture finally became clear. It pointed strongly towards NMS. She ended up needing intensive care. The first absolute critical step was stopping the antipsychotic immediately. And then intensive supportive care, things like IV fluids to try and protect her kidneys from the muscle breakdown products, cooling measures for the fever.
And how long did her recovery take? Did she stabilize quickly?
She did stabilize, but it took about a week in the ICU. And the recovery itself wasn't quick at all. Her physical recovery took months, apparently marked by significant weakness. And understandably, the whole experience left her with considerable emotional trauma.
Wow. That story just... It really encapsulates so many points, doesn't it? The rapid onset, the severity, the absolute necessity of recognizing those symptoms quickly, and how devastating that initial misdiagnosis can be. And it really underscores the vital role family members can play, noticing changes, advocating.
It absolutely does. And the source uses this case specifically to underscore that critical need for better education among all healthcare providers. Anyone who might encounter patients on these meds, especially maybe in emergency settings where they might not be thinking NMS first, sharing these kinds of patient stories, just like the article does, it's such a powerful way to highlight the real-world impact. It raises awareness maybe more effectively than just citing statistics can.
Yeah, absolutely. So, okay, once NMS is suspected or confirmed, what's the treatment protocol look like? What steps does the source outline?
The absolute cornerstone, the number one thing, is immediate action. Discontinuing the offending antipsychotic. Stop the drug. And also stop any other medications that might be contributing, like those dopamine blockers we mentioned. That's the single most important step.
Okay, stop the drug first, and then it's largely supportive care after that.
Precisely. Intensive supportive care is crucial. That means things like aggressive IV hydration, really pushing fluids to help the kidneys flush out those muscle breakdown products, measures to reduce the fever cooling blankets, antipyretics if they work, and constant close monitoring of vital signs, heart rate, blood pressure, oxygen levels, everything.
Are there specific medications used to treat NMS itself?
Well, in more severe or stubborn cases, the source does mention specific medications that might be used. Things like dantrolene, which is a muscle relaxant, or bromocriptine, which acts like dopamine to try and counteract the blockade. But interestingly, the source also notes that strong, high-quality evidence for these specific drug interventions in NMS is actually surprisingly limited.
Okay.
So often, because of the high risk of serious complications like respiratory failure needing a ventilator or that acute kidney injury needing dialysis, these patients really need to be managed in an intensive care unit, an ICU.
Right. Given how serious this is, what about preventing NMS in the first place? Is that possible?
Well, prevention really seems to come down to awareness and proactive management, mainly by the healthcare providers prescribing these medications. The source emphasizes starting antipsychotics at low doses. Don't go high right away. And then increase the dose slowly, titrate slowly, especially in those first couple of weeks after starting, when the risk seems to be highest. Close monitoring during that initial period is really key.
And screening patients, too, for those risk factors we discussed earlier.
Exactly. Clinicians should ideally screen patients for those known risk factors like history of agitation, dehydration risk, maybe prior NMS, and potentially consider alternative treatments if the perceived risk of NMS seems particularly high for that specific individual.
Makes sense.
But honestly, one of the most powerful prevention strategies, highlighted both in the article and really driven home by that real-life case, is educating patients and their families, making sure they know what symptoms to watch for, empowering them to recognize the signs, the sudden high fever, the intense stiffness, the confusion, and know that they need to seek immediate medical help if those appear. That knowledge can be literally life-saving.
Okay, zooming out just a bit then. The source touches on the broader impact NMS has. How does this rare condition affect, say, the mental health system as a whole and the individuals who survive it?
Yeah, it's interesting. For the healthcare system, the very rarity of NMS actually complicates things like research. As the source notes, you might only have a few hundred cases reported annually in a large country like the U.S. It's just really hard to conduct large-scale clinical trials or studies on something you see so infrequently. And that can slow down advancements in, say, better diagnostic tools or refining treatment protocols.
Right, hard to study something rare. And for the survivors.
For survivors, the psychological toll can be really profound. I mean, imagine going through that kind of sudden, severe, life-threatening medical crisis. It can understandably leave people with a significant fear of taking necessary medication again. They might develop symptoms of PTSD. And it could lead to a reluctance to engage with mental health care in the future, which, ironically, can impede their recovery from the original mental health condition that required the medication in the first place. It's a tough situation.
Yeah, that's a really difficult consequence. Are there groups advocating for, like, better understanding and protocols around NMS?
Yes, absolutely. The article mentions ongoing advocacy efforts. Organizations like the National Alliance on Mental Illness, NAMI, for example, they're involved in pushing for better awareness, improved diagnostic tools, and importantly, enhanced training for medical professionals to ensure NMS is recognized and treated as quickly as possible.
Okay, so pulling it all together then. Neuroleptic Malignant Syndrome, NMS. It's this rare, yes, but incredibly dangerous reaction. It's linked primarily to antipsychotic medications.
Right. And it hits with a specific cluster, that tetrad of symptoms, high fever, severe muscle stiffness, altered mental status, and that autonomic system going haywire.
It's a major diagnostic challenge because it looks like other emergencies, but spotting it early is just absolutely critical.
And the risk factors seem mainly related to how the drug is started or adjusted, but also include individual patient factors, maybe even environmental stress. Treatment is basically stop the drug immediately and provide intensive supportive care, often in the ICU.
And maybe the most powerful tool we have right now is simply awareness educating everyone involved, from doctors to patients to families.
Absolutely. It really underscores that delicate balance, doesn't it? Treating serious mental illness often requires powerful medications that are genuinely life-changing for many, many people. But they can carry these rare, yet potentially devastating risks that we just need to be vigilant about.
So thinking about the listener, what does this all mean for you listening right now?
Well, I think if you, or perhaps someone you care about, is taking an antipsychotic medication, understanding these potential signs of NMS, even though it's uncommon, it's really crucial. It's not about creating anxiety or fear or unnecessary treatment, not at all. It's about being informed, about vigilant awareness. Knowing the key symptoms, knowing the main risk factors, means you can be a more active participant in ensuring safety. You can ask the right questions, you can raise concerns quickly if needed.
Yeah, it really makes you think about that specific example from the source again, doesn't it? The difference that family vigilance made in that young woman's case. It just highlights the power of patient and family knowledge. How being informed about these rare but potentially devastating risks isn't just academic knowledge. It can literally be the difference between a delayed diagnosis with severe lasting complications and rapid intervention that saves a life and minimizes that trauma. That knowledge is actually a critical layer of safety in psychiatric care.